All right. Good morning, everybody. Inpatient palliative care teams, we are often called to help clarify goals of care in patients whose capacity is either undetermined or unclear. And determination of who is the decision maker is one of the very first steps, really, in any inpatient palliative care consult. Today, we'll review a case, the prevalence of incapacity, how to approach a capacity eval, and finish with some of the more common challenges that we encounter in our inpatient palliative care population. Before we start, if I can recommend that you take away just one reference to read from this presentation, I would recommend this little gem here. It is superb. All right. Here we have a real case with most of the details omitted just to be respectful for patient privacy. And I think you will find it familiar, as we've all met versions of John Doe in palliative care. John was a man who had no family, no surrogate decision maker. He spent several weeks in the hospital with a prolonged and pretty tumultuous course. He'd been on mechanical ventilation for an acute, reversible illness that was improving, and it was anticipated that this man could be weaned off the vent over a fair amount of time, and he had potential to recover and get back to his baseline. As John Doe improved, he was able to start mouthing words around the ET tube and consistently told his team, "I want to die." This went on for a few days. He was consistent, and naturally, these statements are causing moral distress with his medical team. They were concerned that they weren't respecting autonomy and that they were contributing to this man's suffering. So palliative medicine was consulted. And when I spoke to the ICU attending, he shared his own moral distress, that something just felt wrong. And yet, this is what the patient was asking of him. This is what the rest of his team was asking of him. And he too saw how much suffering this man was going through. And that ICU attending was able to identify, I think, how emotionally invested he was in this case and how that was making this even more difficult. He was really asking us for a third-party opinion as someone who was not as invested, help support everyone and just do the right thing here. And so we'll return to this case throughout the presentation. Bottom line here is that we as an inpatient palliative care consultant are going to run into many incapacitated patients. It's really imperative that we are capable of making our own skilled evaluation. We see in the literature that incapacity is all around us. It's present in about a quarter of medicine inpatients and approaching about a half of some of the populations that we see with serious illness. And incapacity can go unnoticed. In this particular paper from JAMA in 2011, it was showing that less than half of incapacitated patients were being picked up by their physicians. So it's not uncommon for us to be the first team to identify incapacity. And this is why identifying the correct decision maker is one of the first steps in our consults. There are a few items in the hospital setting that should happen before the capacity eval. Urgency is a factor. How many days or hours do I have with the patient or family to make this decision? Sometimes there's no time at all, and the right decision is acting in the patient's best interest, though this is really less common, I think, in palliative care, much more common in our ICU colleagues, where there may not be time for fully informed consent. But by erring on the side of life prolongation, when goals and limits are unclear, that allows you to slow things down, gather more information, and make changes later, whereas the opposite is not true. Communication barriers are everywhere in the hospital. Do they have their hearing aids? Did they leave their glasses in the car? Do they need an interpreter? Have they even sat down with the medical teams to receive the basic information in order to begin to process what's going on? Is any of this reversible? Can we correct the electrolyte imbalance or clear the infection or remove the offending drug? Then perhaps we can give them more time to allow them to have a better chance to succeed in capacity and therefore participate in their own goals conversation. And then we can proceed to the capacity eval. A capacity evaluation is clinical judgment. It's really an evaluation of the patient's process of getting to a decision. Not that there's a right or a wrong decision. And so naturally, there's going to be some variability in interpreting someone's thought process. And you'll see this variability in clinical practice. I work at several different hospitals within a system and therefore several different psychologists, and there are subtle but noticeable differences between them. Depending on the source you use, you'll see these 4 standards worded a little bit differently, or sometimes even subdivided into smaller but more groups, but they all boil down to these same basic principles. And these are the 4 that I like, but you may have a different preference. Number 1, does the patient understand their medical condition? There's lots of right ways to ask this. What's your understanding of what's going on with your health? Tell me what you understand is going on with X or Y or Z. What are the benefits? What'll happen if you decline, and so on. Number 2, can the patient manipulate logic and information rationally? I personally prefer to use the MOCA here. Do you need to do a mini mental status or a MOCA to assess capacity? Of course not. But I use it probably mostly out of my own habit. But also, if I'm making a formal evaluation, that means I'm stuck in a gray area, and I think this helps me to add to my confidence. Now, the MOCA is really only helpful in the extremes of scores. A low score, under 14 or 15 in a patient who's not meeting the other criteria, that adds to my confidence that they lack capacity. In a high score, maybe a 24, 25, 26, in someone who's meeting the other 3 criteria, again, just adds to my confidence that they have capacity. Number 3, can they appreciate the big picture? Again, lots of right ways to ask this. What would it mean for you to undergo X or Y or Z? How does that impact your future? How does it impact your goals? Help me understand why that's the right decision for you. And number 4, the last one, is simply that they need to have the ability to communicate their decisions and their preferences. It may not be a voice, maybe writing, or blinking, or a letterboard. So let's return to the case briefly of the man mouthing, "I want to die." After our consultation, I saw John twice that day to see if time of day made any difference. On my exam, he continued to consistently mouth, "I want to die." But that's it, right? I could not get John to expand on that and share why he was voicing this statement. And sure, right, it pulls at my heartstrings too, just like it did everybody else. And I could see each time that I was talking with him, he would get more agitated. He looked objectively like he was suffering, right? And I can appreciate the team's moral distress, but this man could not demonstrate to me any of the components of capacity, right? Not even close. And so before we talk about the conclusion of this case, I want to review a few of the challenges. There are many pitfalls to the capacity eval, but here are a few that I think we face in particular in the inpatient setting. So, number 1, we are only human, and sometimes moral distress clouds judgment, which we're seeing here in the case of John Doe. And often palliative care is called, I think, specifically to situations where there is immense moral distress. And sometimes we're consulted in lieu of an ethics consult. There's value in our ability to step in a little less invested as a third party, help everyone in these cases. Here in the case of John Doe, we have a man who appeared consistent and sometimes will repeat a capacity eval over multiple days to allow a patient to prove that they're consistent. But consistency alone is not capacity. Yeah. Boy, when depression and psychosis or other mental illness is a factor, sometimes you'll hear the question, do these diagnoses in and of themselves prevent someone from having decision-making capacity, especially around stopping life-sustaining treatment? You know, and both situations can be true. They may have capacity, or their mental illness could be in a state where it's really prohibiting them from understanding or processing the situation, or maybe overemphasizing a burden or their own worthiness of them receiving treatment. There's nothing wrong with asking our psychiatry colleagues to help weigh in on how much someone's mental illness is or is not impacting their ability to make their own choices. When I make a capacity eval on someone waxing and waning in the hospital, I'll try to see them twice that day, probably even twice the next day. And that investment has paid off, because sometimes you will catch a patient at a lucid moment. And this may be particularly important in our population. For someone who is maybe towards the end of life, when lucid moments are becoming harder and harder to come by, and that moment may be all you have to work with. In the perfect world, of course, we'd have consistency and conversation over multiple days, but sometimes you just don't have that. And I've helped teams and families make decisions from information that was just learned from one temporary lucid moment. Yeah. Religion can be a challenge. Bernard Lowe has some excellent advice here in, I think, just being aware that, number one, yes, we allow patients and families to factor religion into their decisions. But number two, there's a difference between a religious belief and a religious-based psychosis or religious-based delusion, and psych and chaplaincy can help us sorting that out. Right? This is a situation to make really good use of our multidisciplinary team. In the hospital, we may be seeing patients in some of the worst days of their lives. Right? They may be learning of a new diagnosis, waking up with some new physical or cognitive illness. We meet patients who have lost control, who are grieving, trying to regain some of that control. And so this absolutely can impact their perception and their capacity in similar ways that mental illness can. And oftentimes I feel like I see this where they are overemphasizing burdens or suffering that with more time and more processing, they may feel differently about. And sometimes that's just one more day. I'm often leery about making quick decisions in the hospital, especially right after a diagnosis. Slowing things down can be a powerful tool. And here's my last one. When someone is incapacitated, we involve a surrogate. But even when that happens, I still like to have a one-on-one with the incapacitated patient before my meeting with the surrogate. Incapacitated patients, they may not be able to weigh in on a major complex decision, but often they provide the most insight into their quality of life, or how and why or how much they are suffering, or what they're worried about, what they're thinking about. Usually, it's the incapacitated patient that gives me more insight into their goals than the surrogates themselves. And yes, while we need to use that information cautiously, we can verify it with the surrogate and use it as a really helpful starting place for conversations with their surrogate. Here is how our case concluded. So I can remember pretty well that it was not initially very popular to recommend that John was incapacitated. Right? I did not doubt whatsoever that John was suffering in some ways, but I did not believe that he really understood the full consequences of his statements. I recommended that since he was anticipated to be extubated later that week, that we just slow this down, continue treatment in his best interest, because we had no surrogate, and explore this more with him after extubation once we could better vet his perspective and his thought process. After all, in a situation of unclear goals, erring on the side of life prolongation in John's best interests allows us to gather more information and make changes later. Whereas if we extubated him now, he would die, and there would be no more opportunity for reassessment. And that ICU attending agreed and really told us he knew deep down that this was probably the right decision, and just he was thankful that he had someone outside of the case to help him to get there. And again, recognizing how emotionally invested he was in this case. So when John was eventually extubated, he was very agitated. It took more than a week for his hyperactive delirium to clear. And when it did, we were finally able to sit down with him. John had no recollection of the conversations in the ICU. He didn't remember asking anybody to die. And he was thankful that we took the steps that we did. And John really went on to do well. One last point before I'm done here. Another reason why I love sharing this case is that it helps to dispel the very inaccurate myth that palliative care is the angel of death and we're just here to try and lead our patients to hospice. I mean, clearly not true. Especially here, right? I'm here to advocate for what is right for my patient. In this case, it is for the preservation and prolongation of my patient's life and really doing what is ethically right for John. So, thank you for listening, and I will see you out there on the wards. Bye.